So I wanted to talk about thromboprophylaxis, maybe not exactly what you're expecting. So if in terms of the content, so if there are questions, then by all means have questions afterwards. That's absolutely fine, and there should be time for that. Just with this first slide, I just wanted to put this up there to reiterate the fact that I know you all know that pregnancy is a prothrombotic state. Pregnancy increases the background risk of thrombosis for everybody by 5 to 10 times. So you're already starting at that point. And I think it's really important that you remember that every person who's pregnant has an increased risk of thrombosis anyway against their background risk. So the amount of fibrin that's produced increases, fibrinolysis decreases, certain clotting factors increase, and the anticoagulant factors like protein C and protein S decrease. So there's a natural mechanism that goes on board with pregnancy to make women more likely to clot. We're all aware that blood clots are the leading cause of maternal death in this last triennial report, with the 16% of deaths due to blood clots. So I've put 44. I think not quite so good with my calculation there. Claire said it was 43 women dying as a result of a blood clot. And what I hope to do with this presentation is highlight the importance of managing risk factors and thromboprophylaxis starting as soon as possible in the first trimester, while looking at some of the issues around thrombosis. You'll hopefully have an open awareness to take back to your units and push on with pathways for improving thromboprophylaxis management and ultimately making some inroads into reducing deaths. And that's a very familiar slide. So I know we've seen this one already. Again, 1 in 4 women who died from VTE died in the first trimester, and that's 4% of the total number of women dying in the 3-year period. So that's that percentage of women that we actually have the potential for affecting the outcomes for, with hopefully relatively strategic management, we should hopefully be able to reduce those numbers significantly. Okay, so I just wanted to put that slide up there that looks at the maternal mortality due to specific causes, and the darker the shaded box, the higher the incidence. So it's interesting just to see how the UK does compared with other European countries. So for venous thromboembolism, we're quite a dark shaded. And if you look at Denmark and Norway, and the lightness there's quite a significant difference in terms of causes for maternal mortality. Makes you wonder if you'd rather go and live in Denmark or Norway. But interesting, again, the things that we're particularly good at. Okay. So we know from the Embrace slides that blood clots are the #1 cause of maternal death in the UK. And worryingly, our rates are very similar to the rates in the USA. And from that previous slide, you can see that we're clearly an outlier to the rest of Europe. And why would that be? What do you think the reasons are that we have such an increased incidence, that there are so many problems for us here compared to the other countries? Anybody got any ideas? Obesity. Yeah, that's our big issue. It's a big public health concern. And I think the fact that obesity has such an impact is something that we really need to address as midwives and have some of those difficult conversations. I always find the frustrating thing is that perhaps we haven't got the resources to support women in an ideal way with an obesity issue, and we raise the issue and we raise the awareness that you've got a problem that's affecting your life and is going to increase your risk of blood clots through pregnancy, well, there might not be anything we can do to change the overall picture for them in the snapshot we've got in pregnancy, but what we can say is there's actually something we can do about it. Yes, this is a risk factor that's affecting your life, and we can help promote that public health message, but we can also tell them that there's something that we can do about it to keep you safer during pregnancy. And actually having that safety net is really important for these women. So 17% of the women who died as a result of the VT had a normal BMI in the Embrace report, only 17%, and over 80% were obese. And as Claire said earlier as well, our demographic for the Northwest Maternal Medicine Network is one of high social deprivation, and what goes along with social deprivation, increased rates of obesity. So we really have a particular problem in this region, and it's something we really need to address. Looking at that slide, which actually demonstrates from underweight to class 3 of obesity, so the different levels of being underweight through obesity, the red line is the rate of thrombosis at the time of delivery. And interestingly, that's actually really quite stable across every class of from underweight to obese class 3. And I think looking at that, I was trying to work out what is it. Well, actually, we're really good at thromboprophylaxis around the time of inpatient admission and around the time of section. It's something that's developed. I remember years ago when we didn't give prophylaxis for women after a cesarean section. Now it's a checklist. It's something that's looked at. We use below knee anti-embolism stockings when women are admitted. We use Flowtron boots. We manage women really well when they're admitted to hospital. But it's that rest of the time and the fact that the rates are so increased antepartum and postpartum that tells a different story there, really. Okay. And this next slide just demonstrates the incidence over the year from pregnancy to a year postpartum. And as you'd expect, there's a big spike around the time of delivery and in those first 6 weeks postpartum. But what it also shows is how many VTEs or what the prevalence is before 12 weeks. And one of the interesting things for me from this is that this slide is from 2008. It's not new news or new knowledge that thrombosis occurs in the first trimester, but it's perhaps something that we've lagged behind with catching up on, and the Embrace reports have demonstrated that not only is thrombosis becoming a key issue, but it's management in the first trimester. And I think as midwives, that's really where we can step in and do something proactively about this. We've got the scope within our practice and within our own roles, perhaps to change things in our own units and bring an awareness to our own units. So what are the key messages in the first trimester deaths? What are the key issues that are going on? First trimester death accounting for a quarter of the deaths in the report. Why? When this has been sort of looked at and drilled down, one of the main issues is 30% of the deaths were due to hyperemesis and not getting appropriate VTE prophylaxis. Anybody who's had hyperemesis will know that women are dehydrated before they get to hospital. Women are not eating, they're not drinking, and most of all, as well, alongside, they're not moving around normally. If you've had hyperemesis, not that I'm speaking as one who knows, but it's really not pleasant, and you're going to be lying around before you get to hospital. And then I've certainly had issues with accessing women to the emergency gynae unit and getting that as being one of the issues that we're concerned. They've already got a risk of thrombosis and they've got hyperemesis. There should be a low threshold for those women being admitted and being rehydrated if they've already got an issue. And one of the things I was thinking about surely we have on the phone sort of checklist. I don't know how your local emergency gynae units work, but women are triaged by phone with us. And one of the things that perhaps needs to go into that, if it isn't already, is a checklist around what are your risks for thromboprophylaxis, or there needs to be an awareness. I know nobody wants to be admitted to hospital these days, and that beds are an absolute premium and space is a premium and many units are overworked. But if you're asking the woman, is she over 35? What's a parity? What's a BMI? Those things need to be picked up on as well. And is there anything else that the woman needs to be told? Is there any other way we need to be managing hyperemesis? Also thinking about it, if a woman's given prophylaxis when she's admitted to hospital for her hyperemesis, when she goes home, she's still not necessarily going to be back to normal activity or back to normal levels of hydration, but enough to get her by and to get out of hospital. So perhaps we need to be thinking about extending the period of time that women are on prophylaxis for when they've been admitted with hyperemesis. Now, I know for most of us that's outside of where we're working, and that's perhaps a gynae issue, but we all care for women that will have had or will have hyperemesis. So having an awareness of that and keeping that sort of high up on the agenda, and even telling women that we're giving thromboprophylaxis too. If you start getting nausea and vomiting, that increases your risk of blood clotting, and getting that message out there to them. Okay, so abortion care is another significant issue, and most abortions terminations will occur within the first trimester. For the private providers who carry out a significant proportion of terminations, they have no guidance for VTE prophylaxis. And there isn't a service that is going to see a woman and complete a termination on the same day. There's a lag time. Those women are already in their first trimester. They need some prophylaxis if they've got risk factors, and that's something that I don't know where we go with that. We haven't got the answers for that, but it's certainly something to be aware of. Women who come to you and then decide to have a termination within the first trimester still need prophylaxis if they've got risk factors, even if they only score with risk factors that aren't things like having had a previous thrombosis. If a woman's older, multiparous, overweight, has had a previous thrombosis, she definitely needs prophylaxis in the period of time up to a termination, and even possibly afterwards. There are some women, depending on the risk factors, that have either had a termination or have a miscarriage with us that would continue on prophylaxis for a couple of weeks afterwards, because they've still got hormones and changes going on in the body that increase their risk, that make them more prothrombotic. So that's another area that needs work and needs some thought. The other point is that women over the age of 35 in the last decade, there's been an increased number of women above that age group having terminations, and their background risk is increased by 2 from the point of view thromboprophylaxis as well, so the point of thrombosis as well. Okay, so more issues here. Are women falling out of obstetric care, not booking until 10 weeks on average? We've already discussed a bit about GPs feeling uncomfortable to prescribe, but the reality is GPs are no longer in the picture with pregnancy, very much in the early stages. Women are going online and they're referring directly to the provider that they wish to book with. GPs don't come into the picture, so GPs don't have that opportunity. So where are we going to pick that up? I've heard from sources NHS England are planning a wider policy around widening access to pre-booking space, particularly in terms of self-assessment being part of this, in an attempt to identify women that are most at risk. And the thoughts are to get women referred to rapid access clinics and maternal medicine networks being instrumental in this work. I know there isn't nothing set in stone or sort of planned yet, but I certainly think there's going to be some direction coming from NHS England in terms of this, and there are perhaps things that we can do on a local level to improve this straight away, and little gains we can make. Should there be a self-assessment risk tool or questions on the self-referral form that women fill out? That's something that to think about in your local unit. Is that something that you could do? Have a look at your self-referral form and look at the process about who's dealing with that. New risk factors are emerging. So the RCOG VTE tool was never validated and it's 8 years old now, and that this is being reviewed. And there's new data that suggests some new and updated risk factors. So things like physical disability on its own had, I can't remember the ARR, adjusted risk ratio of 3.05, and we're seeing far more women with physical disability of some sort or another, whether that's something that affects their mobility, coming through and having pregnancies with us. So the first thing I always think about when I see somebody in a wheelchair is not what's causing them. Are they on prophylaxis? Have they got stockings on? Do they know that they're at risk of thrombosis if their mobility is that limited? What other risk factors are there? Women with sickle cell, odds ratio, so 10.6 times for any VTE and 11.1 times increase for a PE. The odds ratio and the adjusted risk ratio and the risk ratio are all, I'm sure you all know, but they're all ways of saying your risk is greater than the background risk. And gestational diabetes has a relative risk ratio of for VT of 2.48. So gestational diabetes increases the risk of thrombosis as well. And IVF has a significant increase in risk with an odds ratio of 9.8 in the first trimester. So women going through IVF, and IVF, we're seeing more and more IVF that's been carried out overseas. So women that wouldn't be approved for IVF in this country because of the risk factors. And we had one of the latest maternal deaths from Manchester was a woman who was treated with IVF abroad, and she had, apart from age, she had renal problems and other issues that sadly resulted in her death, and she wouldn't have ever been approved for IVF in this country. And just while we're talking about data, I don't know if you can see any of that, but I'll just whiz through those couple fairly quickly there, just showing you your risk ratio. This is from the RCOG guidelines. So what happens currently? What happens at the moment? So women will either self-refer to a FRAN if they've got one, if they're lucky enough, to a clinic, to our team, to specialist nurse teams. They might go and see their anticoagulant practitioner. Then we may get referrals from GP, and they may be referred in from an IVF clinic. But where do these referrals go, and who do they go to? And this is the gap and the issue with the time scale involved. So what are the barriers? What are the problems for us? Late booking appointment process. How long does it take on average, do you think, for a woman to do a self-referral, the self-referral form to hit admin, for admin to deal with the self-referral, for the booking appointment to be scheduled, for the woman to be seen by a midwife at booking appointment? Talking 3, 4, 5 weeks of the first trimester. If the woman hasn't done a self-referral till she's 8 weeks, first trimester's gone. You've lost that. So really looking at the booking process, the self-referral process locally is one of the things that we can do to start managing this and start looking to improving this. So as I said, the process of referral handling from booking. And one of the big things is you do not need a scan to confirm a viable pregnancy before starting prophylaxis. And if any unit's still doing that, that's one of your easy wins. You can stop doing that now. You really don't need to get a viable pregnancy scan. Yes, and I know Fran does this as well. We see women really early as you think they've barely got out of bed from conception and they've got a positive pregnancy test, and we're seeing them straight away. Fine, that's great. We've got those women. but we're not going to wait another 4 weeks or 3 weeks to scan them before we start them. We start them on prophylaxis and then we get an early scan. Yes, it's important to get an early scan. They want to know that everything's okay with the pregnancy. We want to know that their pregnancy is viable, so we can, they're having a form of treatment that isn't very nice, and we can confirm that they need it at that point. So yes, get an early scan, but don't wait for a viability scan before starting prophylaxis. That adds another element or another step of, well, who's going to review them after the scan? Do they need to come to the clinic? We've certainly got doctors in the clinic still that have been saying, no, I won't start her. She needs a viability scan. Don't need to do that. They need to start straight away. So there's no specific pathway for referral to a specific clinic for women to be seen in. And this is again something we can look at locally. If you've got the facility to set that up, do you have the confidence to see women? Do you need skilling up for midwives to be able to see women and have a conversation with them to discuss the risks? We have a smart phrase, like everyone has, that we put into the women's notes, and attached to that's a video that shows women how to give their injections. So there's lots of resources that are available to help make things better for women. One of the other big issues and barriers for women having thromboprophylaxis from the first trimester is compliance with the regime. Women don't like injecting themselves and may need to feel they've got access to some kind of support for this, that there are materials available for them. For the 3 maternal deaths that were directly related to thromboprophylaxis or treatment that occurred in recent years, at St Mary's, 2 of them were directly related to the women stopping taking their treatment in the postnatal period. 2 of them, I'll never forget the guy who came back to see us, woman I'd seen multiple times through 1, 2, third baby, had complex antiphospholipid syndrome, just got fed up with it and decided, I'm not going to bother taking it anymore. She died. She had a thrombosis and died. And I remember her husband coming in with 2 little children and a baby in arms to see us, just as a sort of, he wanted to see us and talk to us. And I could have cried. He said she just got fed up with it and I didn't stop her. I didn't make her take it. And she died. That was just absolutely heartrending. Another woman with a heart condition died, leaving 3 children. And there was another woman who was far more complicated, but her compliance with treatment was one of the things that was suspected through the pregnancy. And she eventually had a stroke and eventually died from thrombotic causes. So compliance can be an issue. And you were asking about 10A level monitoring in women on prophylaxis. No, for women on straightforward basic risk factors prophylaxis, we don't do it. But sometimes there can be a place for doing 10A level monitoring for women that you're concerned about the compliance with. If you're looking for tools and levers to try and get them to take their treatment, that can be something that's worth doing. And looking at the tummy and seeing have they got any evidence of injecting themselves. The woman that we suspected of not taking a prophylaxis had bags and bags and bags of heparin at home that her husband bought in after she died. If she'd been taking it, there wouldn't have been bags of heparin. So yeah, compliance can be a big issue. Okay, so actions moving forward. Can't stress it enough. One of the easy wins you can get if you're not already doing it. No need to arrange viability scan before commencing prophylaxis. Review local processes and available resources. Review current guidelines. Thinking about self-assessment tool for women on self-referral for care. GP prescribing guidance. I think the GP prescribing is going to be less of an action, but it's something that we're thinking about. And just a brief family case study. I looked after just that it tells you a little bit about risk and what you would perhaps what we'd expect or what we learned. So I first met a mum in her first pregnancy. She had her first DVT in her early 20s after having her first baby. She had no other risk factors at the time, so she wouldn't have been started on prophylaxis. And you're scratching your head a little bit thinking, why is a young, fit, healthy woman in her second pregnancy had a DVT? Anyway, she was found to have factor V Leiden at that stage. Second pregnancy, 6 weeks gestation, she had a massive iliofemoral DVT. And I remember that because I was chasing her around, trying to get hold of her to start her on some prophylaxis. And she was an inpatient, having had a massive thrombosis. And she was left with ongoing morbidity as a result of the post-thrombotic syndrome in that leg. So she had basically a painful swollen leg that's gone on and on being a problem for her. On long-term anticoagulation following that second thrombus. Went on to have 3 further pregnancies, all managed with treatment dose, low molecular weight heparin, and worsening issues of that left leg in each pregnancy. Okay. So her first daughter, 19 years old, normal BMI, unplanned twin pregnancy, family history noted. She was offered screening. In the time she was waiting to have the screening, we got the result. She had a thrombosis, was found to have factor V Leiden. Daughter number 2, 17, normal BMI, unplanned pregnancy. She got on the phone and said she wanted prophylaxis straight away, didn't want any messing around, started at 5 weeks and was not to be persuaded otherwise. She'd seen the history. She was factor V, had screening and was factor V Leiden, and she had an uneventful pregnancy with no VTE. Okay, so what are the messages? Effective early thromboprophylaxis management. We need early risk assessment, pathways for advice, pathways for referral, access to thromboprophylaxis, and hopefully we can really work at reducing the maternal death due to thrombosis. Any questions?